Hello and welcome to Opt to Thrive, episode 28. Lichen sclerosus, a serious cause for itching down there.
Welcome to Opt to Thrive, your go-to podcast for women's wellness in midlife, designed to educate, support, and inspire you to live your very best life. And now your host, Dr. Karina Sims.
Hello and welcome. It is the end of a Sunday. I have had a pretty big weekend. The sun is all but set. There is some tangerine still left in the sky, a little bit of very light peach. It's a lovely finish to a beautiful weekend. I also had a few fairies move into my garden over the weekend. I have a few little solar lights, little fairy houses in the garden, and I've added to them this weekend. They're gorgeous. I love looking at the little houses. About this time of night, the lights come on and they're, a warm, soft glow from their little houses, and they all just look so happy out there. I've had a usual Sunday with the girls. We've done our bike ride, which was pretty challenging today. And then we jumped into the river, and the water's about, I think, 17 degrees, I think they said today. So it's getting a little bit chilly. I did wear my neoprene booties and gloves and skull cap today, which probably looked pretty funny given that I was still wearing my one-piece swimsuit. But my hands and my feet and my head were toasty warm, which was nice. And we had a beautiful blue sky and some glassy water. So it was a really, really fabulous swim. If you listen to one of the recent mindful moments, I've been preparing the little unit on our property that we usually use as the pickers' quarters as a guest house for my best childhood girlfriend and her husband who are coming to stay. So I have spent the rest of the weekend just doing little odd and end jobs around there, doing some like handy woman repairs and more cleaning and just putting on some finishing touches. So it's getting close now. Probably by the time that this podcast airs, we will have had our visit. And then maybe I'll give you a little update how it went. We're going to take them to an AFL footy match in Adelaide, which is going to be pretty cool for them. And then we'll stay down at the beach, which is one of my favorite things to do when I get to Adelaide. So today we're going to talk about something that I have been wanting to talk about for a while. It's a really important condition that could be mistaken for something that women might just think is a normal thing that's happening during menopause. Recently, I put up some posts on my social media accounts, and I've mentioned before that a couple of them went viral. Again, I think it's pretty funny going viral at 54. These posts were about the genitourinary syndrome of menopause, so GSM for short. And they've gotten nearly 2 million views, a couple of them. And then I've put on a little bit more after that. And every time I mention this kind of things, there's so much interest in them. So it made me realize that this is an area that we probably talk even less about than menopause itself. And you know what? It makes sense. Not many women go around talking about their itchy bits. And a lot of women would just assume it's all just a normal part of the process, right? So, GSM certainly is a very common part of what happens to the vulva and the vagina after the decline in our estrogen around menopause. But this particular condition that I want to talk about today is different. And I want to bring awareness to it for a couple of reasons. Number one, the symptoms are treatable. And number two, there are some really serious risks associated with it that women really need to be aware of. So when we look at common things, common causes for vulval itchiness and or soreness, we think of a couple of things. Number one is probably thrush, right? Yeast infection. A lot of women get those. They're a pretty common thing to get. Along with itch, there's often a discharge, that white, thick, pretty discharge, and maybe some soreness and maybe some redness. Another thing that we might think about is contact dermatitis. So the skin's reacted to some type of irritant or an allergen, usually a soap or a moisturizer, a pad or panty liner, washing detergent, something. We might not identify what it was. In fact, a lot of the time we don't really work out maybe what caused it, but then the woman gets some inflammation and some itching. And if we're looking at a woman around the time of menopause, then GSM is certainly one of the things that we consider. Then there are some less common conditions like the one we're going to talk about today. Less common, but super important. And you're going to find out why very shortly. All right, so enough of the suspense, right? The condition is called lichen sclerosus. Now, if you look up the numbers of women affected by lichen sclerosus, you're going to find in general 1 in 70 women. But postmenopausal, around 3% of us are going to suffer from this condition. However, we have to keep in mind that we know that this condition is underdiagnosed. And I know in my practice, I haven't actually done the math, but I am sure I see a lot more than 3%. But if you look it up, that's the number you're likely to find. So not only is it underdiagnosed, but when it is diagnosed, it takes an average of 5 to 15 years to get the diagnosis from the time the symptoms start. This is because a lot of women are too embarrassed to mention it to their doctor. And then when they do, sometimes maybe the doctor isn't having a look. And with this condition, having a look is the key to identifying it. Because from the history alone, the symptoms, as we just heard, can be mistaken for other things like we just talked about. So let's break it down. What is lichen sclerosus? Lichen sclerosus is a chronic, so it's a long term inflammatory skin condition. It mainly affects the genital and the anal areas. It can sometimes appear elsewhere on the body, but that's even more rare. It typically shows up as thin white patches of skin that can cause itchiness, soreness, pain during sex, and discomfort when urinating. The most commonly affected population is postmenopausal women, but it can also occur in younger women, men, and children. But again, that's pretty rare. We don't really know what causes it, but it looks like there could be both a genetic and an autoimmune component. It does seem to be more common in women with other autoimmune illnesses like thyroiditis, alopecia areata, vitiligo, pernicious anemia, and ulcerative colitis. Lichen sclerosus itself is often considered to be an autoimmune disorder. So, an autoimmune disorder is when our body's immune system, which normally protects our body from infections and diseases, gets a little confused. And then by mistake, it starts attacking our body's own healthy tissues. So instead of recognizing these tissues as part of the body, the immune system treats them as threats, and this causes inflammation and damage. As I said previously, it does mainly affect postmenopausal women, and there may be a reason for that. It's thought that the decline in estrogen that occurs around menopause could be the factor. One study that I came across found that postmenopausal women with vulvar lichen sclerosus had lower levels of estrone, so a type of estrogen our body makes, and higher levels of progesterone in those tissues when compared to women without lichen sclerosus. Another study found that the changes in the microbiome, so essentially the microbiome is made up of microorganisms like bacteria and fungi. We all have all these different bugs living in the vagina and around the vulva. The microbiome in women with lichen sclerosus was different than those without it. So they thought that the microbiome changes might be a factor as well, which is all kind of tied together with that lack of estrogen. Now, if you were to have a look at the affected area, there would be some telltale signs, as I said. So, really important that there's an examination of the area by the doctor. I'm going to break these down into 3 stages. How long each stage takes is not really all that well defined in the medical literature. All we can really say for sure is that it is a chronic condition and that the progression can be significantly different for each woman and dependent on how it's treated. So, keeping that in mind, in the early stage, so in the beginning, it shows up as small, white, shiny spots or patches on the skin around the vulva and or the anal area, as I said before. They might itch or feel a bit uncomfortable, but some people don't notice any symptoms at all. And the symptoms can also wax and wane, so settle down and come back again over time. We can stay at this stage for months to years before we get to the established stage. As the condition progresses and becomes more established, these spots can grow and join together, forming larger, thin, and wrinkled patches of skin that look a little bit like parchment paper, so white and crinkly. At this stage, symptoms like intense itching, soreness, and pain during sex become more noticeable. You might also see changes in the shape and the size of the vulva, such as shrinking of the labia, so those vaginal lips, as some women may call them, and you might notice narrowing of the vaginal opening. This stage can also last for an extended period of time, and it will often require some treatment to control the symptoms and prevent progression to the advanced stages. So, in the advanced stages, the more severe or long term cases, the ongoing inflammation and scarring can cause some really significant changes to the anatomy. The labia might fuse together, the clitoral hood could grow over and bury the clitoris, and the vaginal opening may narrow even more, leading to problems with urination or sexual activity, as you can imagine. The advanced stage with this scarring and significant anatomical change generally develops over several years, especially if it's not adequately managed. One of my earliest experiences with lichen sclerosus as a GP was in my first year of training. I had an older, pretty fit and independent woman present with symptoms that would have put her in the established stage of lichen sclerosus. She only presented, though, because she had developed these little cracks on the vulva that weren't healing. One look of it told me that she certainly was suffering from lichen sclerosus. So it can be diagnosed clinically by the history and what we see on the examination. But if there's any uncertainty, then a biopsy really does need to be considered. This is usually done by the gynecologist or a dermatologist. So my patient was referred to a gynecologist where she had a biopsy which confirmed the lichen sclerosus, but also unfortunately confirmed what I had been most concerned about, and that is squamous cell carcinoma or SCC. She battled with that SCC for some time, but very sadly, it eventually took her life. Now, you might be thinking, SCC, isn't that a skin cancer caused by the sun? Yes, it is a skin cancer, but sun damage is not the only thing that increases the risk of getting SCC. Chronic inflammation is another well known risk factor. So, burn scars and chronic ulcers are also a couple of other things that are known to be higher risk for SCCs developing. SCC is one of the significant risks of lichen sclerosus and happens in somewhere around 5% of the women affected with lichen sclerosus. And as in my patient's case, it often shows up as a sore that fails to heal. The risk of SCC is absolutely more likely if the inflammation caused by lichen sclerosus is uncontrolled. So we absolutely must be treating it and monitoring it regularly. So, how do we treat it? The first line treatment is using what we call potent to very potent topical steroids. So, very strong steroid ointment, usually. An ointment base is often used over a cream because it's less likely to sting or cause a contact dermatitis. Only a thin smear is needed and it's rubbed only into the affected areas. There's some variation in how it's used for how long, but the most common instruction is to use it once a day for 1 to 3 months, depending on how severe it is. It could even be up to 6 months if it's really severe. After we've got some control over the condition, the ointment can then be used less often, often once or twice a week, just to control symptoms or prevent it from recurring. The itch usually settles down within a few days, but it may take weeks to months for the skin to go back to normal if it's going to. The white patches could improve with treatment, but those structural changes or scarring, if they've occurred, so the shrinking or the sticking together of the labia or the narrowing of the vaginal opening, are not reversible. But treating the condition properly will help us avoid any further architectural changes and scarring. Topical steroids are safe if they're used appropriately, but if they are used excessively or if they're applied to the wrong area, they can cause some unwanted side effects like red, thin skin, burning discomfort. They can cause a rebound dermatitis or make you more susceptible to candida, so thrush. Now, as I said previously, we like to monitor this condition very closely. In the early stages, it's a bit more frequent, maybe 3 and 6 months to start with. And then once it's stable, I have some patients who are reviewed annually now. And of course, it's emphasized that if they run into any trouble with controlling symptoms, if any new changes occur, or if they develop lumps or areas that aren't healing, then they need to come in sooner. It's also important for not only women with lichen sclerosus, but for all of us, really. And this becomes even more important around midlife, that we should be avoiding any possible vulvar irritants like soap. Soap can be very drying to the skin. I advise my patients to look for non soap washes or to just use water in this area. Avoid fragranced oils or moisturizers, tight fitting underwear, and definitely avoid douching. Because these tissues can be quite fragile, using a topical bland emollient like sorbolene on the area may be helpful to use on the area on those days, especially when the steroid isn't being used. There could be some crossover in terms of symptoms with GSM, so treating that might also be helpful. We've talked about GSM in depth in episode 9. Let's talk about sex. So that's a good one to go back to if you want to learn more about GSM and you haven't had a listen to that yet. I also talk about what's happening to our bits as we go through this midlife period. I think it's pretty interesting. So, treatment can be as simple as a vaginal moisturizer, or that may not be enough. And you may want to top up the estrogen to those tissues, which is the culprit to start with. And that is done with an intravaginal estrogen cream or pessary. According to the literature, when lichen sclerosus is severe and not responding to topical therapy, then systemic treatment, as in a tablet, may be rarely prescribed. I agree with the rarely bit. In 20 years of practice, I've not seen lichen sclerosus treated with systemic therapy. Not to say it doesn't happen, but I haven't seen it. And I guess if there is someone listening who hasn't responded to potent or super potent steroid treatment, then to know there could be another option might be a relief. And certainly I would be talking to a dermatologist or a gynecologist about that. Surgery is occasionally required for women who have severe fusion, especially if they've got those functional problems like trouble with urinating or issues with intercourse, then surgical correction may be required. Women who have surgery still need really close follow up and long term treatment with those same topical steroids for all those reasons that we've already talked about. I hope that you found this helpful. I certainly am hoping that I can bring more awareness to this issue. As I said, there are some serious risks that need to be considered, and even some women with lichen sclerosus aren't aware of the risk and possibly not aware of the risk of the significant scarring and the way that those tissues can all stick together. I know that I have seen a lot of women who've been afraid to use long term steroids on the skin. But as I said previously, It's really important that we're keeping this under control. And we can step down the potency of the steroid, making sure that you're using it specifically on those little areas that are affected is really important, and also important in helping to avoid some of those unwanted side effects from the topical steroid. If you can think of someone who might get something out of this, please pass it on. And again, if you haven't yet reviewed the podcast or giving me a rating, please do. I would really appreciate it. It just helps the podcast be more visible to those who are looking for this type of information. And I'm telling you, there are women all over the world starving for this information. And as I said, with those posts on social media, it became very clear to me that this is an area that women really want more information about. I'm hoping that it starts some conversations, that it makes it more likely that we'll talk about these things amongst our girlfriends. It's really important. Okay, well, with that, I will close. I hope that you all have a great week. And until then, I hope you opt to thrive.
The Opt to Thrive podcast is designed for information purposes only and is not engaged in the giving of medical advice. The information provided on the podcast should not be used for diagnosing or treating a health problem or disease. In no way should the information provided by Opt to Thrive be considered medical advice, and at all times the advice of a medical professional should supersede recommendations from Opt to Thrive. If you have or suspect you may have a health problem, you should consult your healthcare provider. The views expressed in this podcast are purely that of Dr. Sims and do not in any way reflect those of the institutions she contracts her medical services to.
Thank you for listening to Opt to Thrive. If you've enjoyed listening, please rate and share the podcast. You can visit our website at opttothrive.com and leave a comment for any subjects you would like to hear more about.